And my name is welcome everybody to our online HIV session. My name is Modester Chiota. I am one of the HIV nurses in Northamptonshire County, and my background, I am a nurse and I've been a nurse for more than 15 years, and in the field of HIV. I started working abroad since 2012 with HIV, but I recently joined NHFT last year, doing the same work. So as a nurse, I had passion for HIV because specifically where I'm coming from Africa, I've been affected by HIV because I lost my beloved ones due to HIV-related illnesses. So when I became a nurse, like during my career as a student nurse, I also went ahead and witnessed people, because I started nursing in 2003. That's when I did my trainings. And earlier back then, people were not yet in the spirit of getting tested early. So unless when they are really sick, that's when they will be diagnosed. And most of them, it was sort of late, but some were put on treatment and they started treatment and were recovered. Unfortunately for some, they didn't make it. So after getting knowledge on what is HIV, its mode of treatment, transmission, etc., I got so interested into it, and I thought I could share information with my family, friends, and everyone. And then soon after qualification, I went to, I'm from Zimbabwe. I went to Namibia. That's where I was practicing, and I was working for the Ministry of Health in partnership with USAID and HIV management. So back then, we also had like lack of knowledge. People were not knowledgeable, like what is HIV, and if they get diagnosed, back then people were scared, but nowadays we are happy because we've advanced, and now we know that it is treatable, and people's life expectancies increased on treatment. Anyway, the plan for the day, we are going to talk about background of HIV in UK, treatment and prognosis, the myths surrounding it, children with HIV, undetectable, untransmittable, the stigma around HIV, where and how to test for HIV. Are we still together? So this is going to be a discussion. I'm not going to be just reading or talking to people. We'll get to a point where we'll ask questions, and I would appreciate if everybody can engage into the discussion, okay? All right, so I've already introduced myself, who I am and where I'm from and what I'm on about. I think everybody knows me now. So if there is anybody with questions, you can just type your question and I'll ask Sophie and Claire to help me and to address those questions as we go on. I forgot to mention that I'm with my team. I'm with our consultant, one of our consultants, Sophie. She will help me as well answer some of the questions, and she's the one who also helped me with the presentation and everything. So what is HIV? HIV stands for human immune deficiency virus. It's a virus, and it is transmittable during sex and unprotected sex or sharing of needles, mother to child transmission, whereby if the mother is, sometimes maybe they are unaware that they are HIV positive and they are not on treatment, or sometimes they are aware and they are not taking their medication well. They can transmit during the womb or during delivery or during breastfeeding. Those are the other ways of transmitting from mother to child. And then contaminated blood products, where blood not screened. But fortunately here in UK, this has been eradicated. We don't have that problem because blood products are screened. So HIV, if it's left untreated, it weakens the immune system of people and it makes people's bodies not able to fight infections. They will be prone to other very dangerous infections, and those are the ones that will eventually cause deaths in people, because HIV itself doesn't kill, but it weakens the immune system, meaning that there will be other infections that will attack the body and eventually leads to death. So at the moment, we don't have cure, but we do have treatment that is really successful, and it is, once you are on treatment and you're taking it well, it is proved that you live as normal life as anybody else. And it has actually increased the life expectancy of people living with HIV. So we have 105,200 people who live in HIV here in UK. And approximately 6% do not know that they have it. Usually people, sometimes they don't even know that they are at risk of transmitting HIV. The other thing, especially in heterosexual individuals, because sometimes it's all about trust, whereby you are saying, I'm married and I'm only with my husband. I'm married and I'm only with my wife, and you don't use protection because he's your husband or he's your wife. But meanwhile, maybe the person had already had the virus, or maybe they are engaging in other things that we are not aware of. So nearly half of the new diagnoses among heterosexuals in UK, they are Black African women and men, despite our population being less than 2% of the British population. So we are part of the minority, but we are almost, all the new diagnoses, we are almost half of it. Approximately half of the Black African men and women are diagnosed here in UK. So it means that they have acquired that virus here. So we shouldn't just assume that we are here and the prevalence of HIV is slow, so we are safe, we can engage in whatever we want to do, because we might end up catching it as well. So practicing safe sex is always encouraged. Treatment and prognosis. So, like I said, it's now, the treatment works very well. So the life expectancy on treatment is increased and you live a normal, near normal life. And the earlier you get tested and treated, the earlier, the better. Unfortunately, 50% in the Midlands still diagnosed late. And the other good news that we have is that oftenly the treatment, you just take one tablet once a day, or sometimes 2 tablets once a day. It will be a combined therapy, but in some cases whereby there is issues of resistance or maybe allergies, there are a lot of issues that are put into consideration when you are picking a regimen for people, maybe because they've got some allergies or resistances, so they end up having different medication for them. But anyways, all of them have proved to be working as long as you're taking them religiously. So we are going to talk about the myths, and we are going to sort of try and find out whether it's true or not, because there are a lot of things that we have heard, what people say about HIV. For example, how HIV is passed on. Some people, they say that it's passed on by kissing. Or some have been asking, can I have sex with someone when I have HIV? And some people, when they find out that they are HIV positive, they isolate themselves. They don't, if they were seeing someone, they will rather be alone, and thinking that if I start dating somebody, I might end up transmitting the virus. So they just decide to be alone. And children, like if you want to have children, you'll also be thinking, will I pass it on to my kids, or maybe I shouldn't have kids and all that. If I cut myself, can I give HIV to my family? I can't do my job if I have HIV. Or if I have HIV, I have AIDS. And unfortunately, even as advanced as we have come, it seems that some people, they don't even understand the difference between HIV and AIDS. And sometimes people, they get discriminated. People, they are still using the word AIDS for someone who is having HIV, of which AIDS, it means acquired immune deficiency syndrome. It's a syndrome of diseases that comes whereby if the HIV has not been treated, it can progress to AIDS. And nowadays we hardly see that, because people, they take their medication and the medication has proved to work. So from all these questions that I have said, they are all wrong. You can't pass HIV through kissing, and you can have sex if you're HIV positive. You can also have kids that are HIV negative, as long as you're on treatment, you're undetectable, taking your medication well, and doing other things that we'll learn about later on. Are we still together? Or I'm talking to myself?
You're doing very well. Actually, Modester, there's a couple of, well, there's a question in the chat. Donna just asked, do we still test for HIV through A&E? Do you want me to answer?
Oh yeah, that's a good question, Donna. Yeah, we are still doing that, and we're actually trying to do as much as we can to make sure that it has already been rolled out. It's called opt-out, is it, Sophie?
Yes.
So in A&E, it's like everyone is offered and they consent to it, unless if they decline, then they will not be tested.
And just for everybody else on the call, so that's happening in Kettering General at the moment through medical admissions, and we've just got that made a permanent thing, and we're working really hard to get that done at Northampton as well.
Yeah, thank you, Donna. That was a really good question, because honestly speaking, some patients are missed because if we just sort of look at, maybe this one is at risk, so let's give him the test. Sometimes we miss people. So it's really something that has come up. And like Sophie said, in Kettering, we are doing well. We have done so well. Is there any other question that I missed?
Not yet.
Oh, okay.
You're good.
All right. So I'll go on then. HIV and children. Okay, so all pregnant mothers in UK, they are offered to test for HIV, and most of them, they get tested, and then if you are found to be HIV positive, obviously, because they are carrying life, they would also want to prevent their babies from getting HIV. So they usually start medication immediately, and it has proved to be effective. 1 to 2 out of 1,000 babies born with HIV might end up also with HIV, but you can see that it's a really low number. So it shows that the treatment really works. So the main risks are through the womb, and this risk can also increase if the mother is not taking a medication well, or sometimes it can also be through delivery. Also, it also goes to treatment. If the treatment is not being taken well, that's the most cause of the increase of the risk. And also through breastfeeding, we encourage mothers not to breastfeed, they bottle feed to reduce the risk as well. And while they're pregnant, we also encourage safe sex and like the partner, if we know their status as well, it will be good for the partner to be tested, and also to, if it's positive, to be on treatment and checking their treatment well. I see somebody raise their hand, Rumbi Mokoi.
Yeah, thank you. I just wanted to ask, in terms of the stats, really good program, by the way, that you share, information you're sharing.
Yeah.
Wanted to just ask, in terms of the people that are diagnosed with HIV, I think from what you said is half of the people in the UK, they originate from Africa. And I just did wonder, how do you manage, I guess, the element of raising awareness? I know you're already in our communities raising awareness about this, but what else is being done to ensure that our communities, especially the African community, is fully aware? Because I come from a point of where I work with young people, teenagers mainly, and they're now very sexually active. Some of them are now very sexually active.
Mm-hmm.
And I am not so sure whether this information is readily available to them. We do sexual health, in our sessions, but it's not a commonly talked about sort of like topic. Like, I'm in my 30s, so I left Zimbabwe when I was like really young, and I was fully aware, we're educated about it. But I just do wonder, with maybe some of the adults that are here and some of their children, actually, they don't know that they carry the virus. I'm just a little bit, I guess, concerned in that regard, that as a youth worker, it's not talked about really.
Yeah, you are right. Thank you so much for that question. Yeah, it's something that hasn't, like, you will see when we go ahead on one of my slides, you see that there are some people, when they come to get tested, it will be like they have rough idea of what is HIV and the mode of transmission. Like I said, some people, they don't even know the difference between AIDS and HIV. Yeah, so it's something that we are just starting now to try and talk more about it. That's why we have even started with these sessions. We are hoping that we'll reach quite a number of people with the same message, and we hope that it will help people to also to just be aware of it, because sometimes, like I said, most people, they've got this idea that since UK has got a low prevalence of HIV, so they sort of think that, oh, there's not much of HIV, and they just sort of relax. So yeah, with these platforms, we hope to reach a lot of people. And Sophie, can you please maybe help if there is anything else?
I'll just fill you in on what's happening in the county. So in terms of young people, I completely agree. 20 years ago, there was a huge campaign in the UK to educate people around HIV. And that has not been a priority in the last few years. And I think particularly for teenagers coming through now, they're more worried about other STIs or pregnancy risk. So there is a campaign to improve this in schools, and it is part of the RSE curriculum now to talk about HIV. But what I'm trying to encourage our outreach teams to do, and also through the school contacts we have, is to normalize it insofar as we talk about it as something that should be discussed, and that it's not just talked about in the biology lesson as I have a 16-year-old daughter, that they learn about gonorrhea as a bacteria and they learn about HIV as a virus. It shouldn't be, I don't think, discussed in that way and medicalized in that way. It should be about educating us as a community. So there is some work going on, and our outreach team are also doing quite a lot on social media. So that's platforms that I don't necessarily look at because I'm in my 40s, but a lot of the young people are on Instagram and things like that. So Modester, just one of the people who's on the call said we could maybe do the questions at the end, just to say there's not much left of the presentation, so there'll be loads of time for questions.
yeah, I saw that, and I agree with Florence. Thank you so much. I'll just go through the presentation, then we can discuss at the end.
But please put your questions in the chat and I'll save them up.
Yes, thank you. Yeah, so most of our medication are not harmful in pregnancy. People who are pregnant can take medication well without any side effects, or without harming the baby or anything. So it's something that is good. So the medication in pregnancy protect the unborn baby. Oh, sorry. No, I don't know what I did with my slides. Let me just go back to it. Okay, so U equals to U. Undetectable means untransmittable. There was a study that shows that when your when your HIV viral load is undetectable, it means that you can't transmit the virus to someone else. So it has also helped a lot in people living with HIV. That's the time whereby they can also start planning to conceive, and during that time, if they don't want to use protective, they don't want to use condoms with their partners, they can do that, knowing that they will not be able to transmit the virus to anyone. And even during that time, when somebody is undetectable, even if, like for example, if you accidentally, sorry, the words are going out of my head. So if you accidentally, like maybe you are a nurse or you're a surgeon performing an operation on the patient with HIV positive but undetectable, and you accidentally maybe prick yourself, you won't get the HIV from that incident. So it's something that is good. So today, like I said earlier on, we've got an estimate of 105,200 people who live with HIV in UK. And the recent research found that 63% of the public do not remember ever hearing about HIV in the past 6 months. So Rumbi, you were right, you see. It's a topic that we really have to work hard and try to normalize and talk about it, as much as we talk about diabetes mellitus, we talk about hypertension and all other disease conditions. But we do have our World AIDS Day that we celebrate each on the 1st of December each year. And we also try to make awareness of HIV during that day, but on daily basis is something that we should keep talking about. So we've got this big elephant in the room that we need to address: stigma. It is we are sort of improving, because when we started hearing about HIV back in the 90s, it was something that was really difficult, because the minute people hear that you're HIV positive, they don't want anything to do with you, to be associated with you and all that. Of which after all these research and all the advance in medication, we found that it has also reduced the stigma, because nowadays you never see somebody who is HIV positive and taking their medication who looks sick, like who's got advanced HIV disease. So we would like us at NHFT, Sexual Health Department HIV, We are a very small team, and all of us, we work as a team, try to make sure that our patients feel not discriminated. And we always tell our patients that, like, for example, if they don't really feel comfortable to, like, for example, if we meet in a public place, if they don't want people like to ask, where do you know this one from, whatever, I will not be the one to say hi, unless if you come to me and acknowledge that you know me, and then we can just talk, and we don't really have to tell people where we know each other from. Honestly, it's something that we just let the people decide whether they would want to talk to us. It's not because I'm not friendly. If you see me maybe in a supermarket and I don't acknowledge that I know you, unless if you start talking to me, I'll not, just because with the work that I do, people might think, oh, if people see me talking to you, what would they think? Maybe they would think I'm also your patient and all that. But what I'm trying to say is we just treat HIV people like anyone else, because it's just a disease, just like anything else. And the good thing is it's treatable. So we have started this education, like trying to educate even fellow healthcare staff and members of the public about the effects of HIV, the myths and what it is, how it's being transmitted. This will eventually reduce stigma, hopefully. And we do have some website that people can visit and get more information, like this info@tacklehiv.org. You can get a lot of information on HIV, and then educate yourself even with friends and relatives and everyone else. So we can follow them on social media and try to learn more. So why should we test? Because the earlier you test, the better the outcome. And life expectancy is now normal on treatment. If you live with HIV and you don't know it, you can pass it to others without knowing. And that's what has been happening a lot of time. Because here in the UK, if you pass HIV to someone knowingly, it's a prosecuting crime. You can be prosecuted for that. But most people, unfortunately, they pass it on without knowing that they are HIV positive. So if you are on treatment, you cannot pass the virus on. And no one needs to know. If you're HIV positive, you don't really owe it to people to tell them that you're HIV positive. You can just, you choose who you want to talk to about it. If not, you'll still be okay. So how and where and how to test? There are some sites online where we can access the test kits, like the free Test Me site. And you can go there and you order your test kit. They send you the kit, and then you do your test, you send it back, they will text you the results. You can also go to your GP. We do have sexual health clinics all around, and also in hospitals and departments, they do that. There are online providers, and also some pharmacies, they sell those self-test kits. PrEP. What is PrEP? PrEP is pre-exposure prophylaxis for HIV. And who is it for? PrEP is for anyone at high risk of getting HIV. And how can I check if I'm eligible? The Terence Higgins Trust is a handy website to get information about all this. How do I access PrEP? You can access PrEP via sexual health clinics. So PrEP is one of the measures that the Department of Health is put in place to try and minimize new transmissions because it's given to people who, who are at risk of catching HIV. Like, for example, I gave an example of a surgeon or doing like operative procedure, and then they expose themselves with infected blood. So like if the person is not undetectable, or maybe you don't know their HIV status, you can go ahead and get the PrEP. So there is an eligibility criteria for taking PrEP. And you can actually access everything on that THT website, as well as sexual health clinics. So is PrEP right for me? It's something that you should like think when you think, should I get PrEP or whatever, and you're not sure, it's better to just give us a call, and then we can help you, guide you through it. So people who can get PrEP are those who are having incentive or receptive sex without a condom with someone who is HIV positive and not on effective treatment, or if you don't know their HIV status, and if they are from a population group or country where HIV is most common. And if you are having sex without condom, then there is a possibility of transmission of sexually transmitted infections as well, STIs, and unwanted pregnancies. So you should always screen for STIs if you have engaged in unprotected sex. We shouldn't only worry about HIV, because there are other infections as well that we get from unprotected sex. So if you're at that risk, you should also sort for contraception so as to reduce risk of unwanted pregnancies. So if you think you have been exposed to HIV within the last 3 days, that's when you can use the post-exposure prophylaxis. It is known as PAP. So it should be used in that window period of 72 hours. So the earlier you start it, the better the prognosis. We have reached the end of our slide. So this is the time for questions or additions or anything that people would want to discuss.
So Modester, it's Sophie. There's lots of questions in the chat.
Okay.
So I'll go through some of them. Just to clarify as well. So we forgot to put a slide in about PEP, didn't we? So for everybody, actually, shall I show my video just quickly? So you know there's not a voice just talking to you. So hi everyone. Just to say that PrEP, so what the thing we had the slides on is prevention for HIV. And PEP's very confusing. PEP is what you take after you think you've been exposed. So the tool that was on the slide was for people to use. It's on the It Starts With Me website, where you can type in whether you think you would be at risk of HIV, i.e. you're from a higher risk population, and then it will tell you whether you're eligible for PrEP, so prevention. So we're trying to raise awareness for everybody that PrEP is now available. And PEP, if you think you might have been exposed, as Modester said, in the last 72 hours, then you need to contact either A&E or a clinic, and we will discuss with you whether it's sensible for you to have treatment or not. And that's a 28-day treatment. Cool. Modester's relaxing now. That's good. She's done her talk. So shall I read the questions out, and then we can muddle through them together? So we talked about testing through A&E. Yep. And then how often are children screened after birth? That's a question from Donna.
Okay.
Do you want me to answer, or do you want to answer?
You can go ahead.
I'll go ahead. I'll let Modesta have a rest. So if a mother is diagnosed with HIV during during pregnancy, then all children born to that mother will be screened after birth within the first 2 weeks, and then usually within 2 to 3 months. And then nowadays they've changed the rules, but it used to be 6 months and 18 months, and now it's 6 months and 2 years. So that's just to make sure that the babies are negative for HIV. And although we don't advise breastfeeding, if a woman does choose to breastfeed, and we support her through that, and there are a number of kind of criteria people have to meet, then we would screen 2 years after they stopped breastfeeding. Okay, so I hope that's answered the question. Lauren says, if you were to have unprotected sex with someone with HIV who is not on treatment, will you be 100% infected from that person on that occasion? Shall I answer this? She's nodding. The answer is no. So it depends what sort of sex you have, and the risk depends on the type of sex. So for heterosexual sex, the risk is around just less than 1% chance each time you have sex. If you are a gay man who is having sex with their partner or a new partner, your chance is up to between 1% and 3%. So it also depends on whether in a heterosexual couple, whether you're the man or the woman. So it's complicated, but it's actually quite low risk. And hepatitis B is much easier to get. So there's probably around a 30% chance of transmission of hepatitis B. But obviously you only need to have sex once to be able to get it. Hope that has answered that. Okay, so yeah, I think Anne's asked this one. Are those with HIV medication categorized as vulnerable? And the answer is it's complicated. So we manage people with HIV and we look after them looking at different blood tests that we do. So one of the tests we look at is the virus level in the blood, so how much virus is circulating. And for most people, if they're on treatment, that virus level, and it's working, the virus level is undetectable, which was what Modester was saying. If that virus level has not been undetectable, so it's measurable in the blood for a little while, because that person's medication is not working, or quite often it's because they're not so good at taking it, then those people are classed as potentially vulnerable, and they were vaccinated first. And then the other group that are highly vulnerable are the people who are not on medication at all, whose immune system is a little bit weak, and for anyone who's on medication but still has a low immune system or weak immune system. So those people are classed as vulnerable. Everybody else who's got a good immune system and is on treatment is still, they were classed in category 6, which is sort of anybody who has a chronic medical condition. So those people were getting vaccinated if they wanted it earlier than anyone else, and their risk for COVID is, we think from the data, possibly slightly increased, but not that much compared to people who don't have HIV. So the summary is, if you're on treatment and your virus is controlled, then your risk from COVID is not significantly higher, but possibly a little bit higher. But if you're not on treatment, it's a lot worse. Okie doke. Oh, there's lots more messages coming in now. Okay, so the next question is, how far, when somebody tests positive for HIV, how far back in their sexual history regarding partners do you go? Modesta, do you want to answer that while I have a quick? So about contact tracing. Oh, she's gone. Okay, I'll do it. Oh no, she's coming.
Okay. Yeah, we ask, like, when last were you tested? And it was negative. So with some people, sometimes it will be their first time to be tested on that particular day. So you can't really tell. So how long have they been having HIV? And so we'll just ask all the partners that they can remember. But if they know, like, for example, you know that 6 months ago you were HIV negative, or your last pregnancy and it was like 2 years ago, or wherever, you know, you were HIV positive. So we'll start from there.
Brilliant, thank you. So the next question is from Francesca about the new injections. So I'll just summarize what's been happening with this. It's been a roller coaster for us in the clinic. We knew for a long time that the injections to manage HIV were coming, but the rollout has happened a lot quicker than we expected in terms of when the information got to the newspapers and the press and how much information we'd been given in clinics. So the HIV injection at the moment is due to be rolled out from April. And it's, just so that everybody's aware, it's not one injection, it's two. It's two separate drugs to treat HIV, one of which is a completely new drug and has not been used in tablet form yet, and the other, apart from in trials, and the other one is a drug which we've been using for a long time. And they have formulated them both into an injection. So when the patient would come in, if they're suitable for the injections, they would come in and have an injection in each, well, it's kind of the upper thigh on each side of their body. And at the moment, we think that that's going to be every 8 weeks. So just to put that into some kind of context, if you are somebody who's stable on your treatment and you've been taking your tablets for a while and you're undetectable, we would see you in clinic twice a year. Some people, possibly, we're moving to once a year. So if you're going to go on the injections, which has some advantages for some people, you would still have to come to clinic then 6 times a year. And the trickiness of it is that those people have to come within a specific time window. So it's a bit like having the depot for contraception. You can't come too early, otherwise you get too high a dose, and you can't come after the injection date, because then the injection isn't going to work and you run the chance that your HIV won't be controlled. So it won't suit everybody, but it will be brilliant for people who struggle with disclosing perhaps their HIV status if they're living in a house with lots of other people. It might suit people who travel a lot for work, who work shifts, who also perhaps have a psychological challenge around what taking medication means to them living with HIV. So we have a number of patients who very, very much struggle with the actual physical tablet, not because they can't swallow it, but because it just reminds them that they have HIV. So for those people, having the injection 6 times a year might be very helpful. And then the other thing just to mention is that in order to get the injection at the moment, the person has to already be undetectable on treatment. So this isn't something we're able to start from scratch for a newly diagnosed patient at the moment. It's got to be someone who's demonstrated that they're already undetectable, and also doesn't have any resistance, what we call resistance to the medication, because a little bit like antibiotic resistance, there are some strains of the virus that will not respond to these particular drugs, and in those cases we can't use it. So I hope that has answered the question, and if there's anything else, any more questions on that, I'm more than happy to elaborate. Okie doke. So Will's asked, are there any support groups in Northamptonshire for people living with HIV? That is a very good question, Will, and the answer is, despite my 5 years of trying, no. So we have a real lack of peer support in Northamptonshire for a number of reasons. The third sector providers that used to do it before I became a consultant here didn't receive enough funding to continue. And we have tried as a unit to set up a peer support group, but it's hard for people living with HIV in our area to be confident enough to disclose their status and want to kind of share their experiences with others. So I'm still very keen to try and get a support group up and running. I know Modester would be keen to help. Our psychologist Claire is also very keen to help, but we need to, we've actually even got some money to train people to be peer support workers, but we've not so far found anyone who's able to or willing to put themselves forward. So if anybody who's on the call who thinks that they know someone who might be interested, please get in touch. Otherwise, there's quite a lot of online support. So Positively UK have great support, Terence Higgins Trust, and there's a place in London called Body and Soul, which does sort of nationwide stuff, but you can actually go down to Islington and see them. They have a lovely building there. They're very supportive, and that's for people living with HIV and also family members and relatives and friends who are affected by HIV. So I hope I have answered that. Okie doke. Oh, Claire says, oh yes, if there's any other topics that anyone who's on the call today wants to hear about in the future, we can totally do that, cover them in the future. And another question about breastfeeding. Is there financial support available for those who spend a lot more on formula? Oh, well, this is a really difficult topic. In some places in the UK, there is support available. And if you are struggling, there are things we can do, but we don't have a specific fund in Northamptonshire for formula feeding. Yeah, so it's a case-by-case basis, really. And then the other question, next question is, how long does it take for you to become undetectable? Well, there you go. That's one for you, Modester. You can do that. Oh, you're on mute. Oh, it's not me. It's not unmuting. You want me to answer that, don't you? Okay. Yay, there she is.
Sorry about that. Can you say the question again? Sorry.
The question was, how long does it take for someone to become undetectable when they start taking their medication?
Oh, that's a good one. Yeah, it's surprising because some people it's so fast, like within 4 weeks, by the time they come to do their bloods, they're already undetectable. So, but in other people, it take a bit longer, up to 6 months or so. So it just proves that the treatment works effectively and it's very fast.
Great. Let me do the next one. Lauren says, do the majority of those who test positive for HIV want treatment? We're thinking along the lines of those with cultural and religious beliefs, and are there some people who don't want to have treatment? Oh, Modester, you can answer that.
Yeah, most people they are keen to start as soon as possible, but there are some who still have some. It's because of religion, and they will say that they will try other means so that they can be cured, and they don't believe in it or whatever. But very few of our patients refuse treatment. And then we do have a few who are like not on treatment and their bodies have managed to control the viral load on its own. We call them, what do we call them, Sophie?
Say that again, sorry.
I was saying we do have those that just their bodies can control.
Oh, yes.
Yeah,
they're called elite controllers.
Elite controllers, yes.
Perfect.
So yeah, but very few, most of our patients, when they test for HIV, they are very keen to start the treatment.
Cool. Sorry, I was a bit distracted because I'm just replying to a couple of things in the chat. Details in the chat. So Florence has asked how you get in touch with us. So at the end of this, I will put our contact details in the chat. Oh, I'll put the details in the details I've put here. That's no good. Okay, brilliant. So let's just pop here. So yes, Will says, in terms of testing, is it true a test might not show positive until 3 months after exposure? So the latest guidance, which came out last year, is very specific. It says that if you do a 4th generation antibody antigen test, which essentially is looking for antibodies to HIV and also to the virus itself, then then you can test at 42 days. So that's 6 weeks. So if you test 6 weeks after your exposure or the time that you think you had a risk and it's negative, then you are actually negative. So some people still test at 3 months because the window period for syphilis and for hepatitis B, and to a degree hepatitis C, is around 3 months. So some people come back at that time and just retest for HIV, syphilis and the hepatitis, but you don't need to wait until 3 months now.
Oh, sorry, Sophie. I can't. Somebody sent me a direct message, but I can't respond to it.
Okay.
I don't know what's going on with my.
No, I'll sort it out in a minute. Yeah.
Okay. So it says that can we switch from injection to tablets?
Oh yes, no, I've done that one. Yes, you can. Yeah. Well, I'll answer that anyway. Yes, you can. If a person's been taking tablets, and they go onto the injection, and as long as they have come for all their injections and they just don't like it, for example, they can definitely switch back to their previous medication. We're expecting that, I'm expecting that will probably happen a fair bit, because some people do get injection site reactions, like if you're an insulin user and you sometimes get changes in your fat deposition, people have noticed injection site reactions on the trials for the injections. So yes, you can switch back, and it won't have compromise that person's treatment. Will the names of the organizations, what I'll do is I'll put them in the chat. And then Francesca says, any advice on how we can stop the misinformation on the Instagram and TikTok? Oh, Modester, there you go, over to you. The short answer is no, I've no idea.
No idea. People have been misleading people. Honestly, I don't know if they can be shut out or whatever, but yeah, there's been a lot of misinformation, especially on TikTok. But I don't think we are in any position to stop them.
No, I agree. And it's really difficult, because I think, having got teenagers myself, Rumbi, I've noticed you got your hand up. I won't forget you, I promise. It's very difficult because I can't keep a watch on what they're seeing, and the problem is that it gets forwarded so quickly. So I think the only thing we can do is try and propagate the messages that are true, and the more we put out in social media about what the truth is, then I think that's all we can do. But this has been going on for years. I remember about nearly 15 years ago, when I was working in London in a clinic, and a man came in and he was absolutely adamant he'd seen some stuff on the internet, on this website called aidscure.com. And I had a very long discussion with him, and I was trying to explain that this was not a proper website, and that if there really was a cure, it wasn't that the doctors were hiding it from him. It was just, if there was a cure, I would have given it to him. It's just that it wasn't true. So okay, so Tish says very sensibly, the phrase elite controllers is very othering for those who can't control it. I agree. I think it's a terrible phrase, but it's come out of, I don't know whoever came up with it, actually. It came out of the fact that these people are able to control the virus without needing medication. And then another question was about, does that person still infect others? Which is a fantastic question. So without being too medical about it, there is a cutoff for the amount of virus that is in the body, and our cutoff for our tests is, depending on which laboratory you go to, is either less than 50 copies per mil of blood, or less than 40 copies per mil, and sometimes less than 20. But what that means is that there will always be some copies that are circulating in the blood. So, and the phrase elite controller just refers to somebody who has never required treatment because their virus level has never come above that cutoff. But we know from research studies that some very clever tests will detect virus down to several copies. So maybe 5 copies in a mil or 10 copies in a mil. So we can't be 100% sure that those people that are termed elite controllers cannot infect other people, and we do now still offer those people treatment. Having said that, if somebody in that group doesn't want to take treatment, then we think that the risk is tiny, because the studies that were done looked at the cutoff of less than 400. So we know that those people are going to easily be less than 400, and so the risk of passing on the virus is very, very low. But it's difficult. It's difficult. I've not seen a transmission in somebody who controls their virus ever. But we are very confident that if you're on treatment, you definitely can't pass the virus on, because there's so many very, very large studies that have shown that. Okay, right. I can't even see your hand now. Rumbi's got her hand up. Go for it.
Thank you, Sophie. Sorry, I can't type. That's why
That's
I
all right.
raising my hand. I wanted to just find out in terms of what other partnerships you're doing in terms of, because I was really, really moved by the stats in terms of the African community. And I just wondered, in terms of like some of your outreach work, does that entail religious leaders, because they've got a huge influence within our community? Sorry if the question has already been answered. I had to step out for a moment. They've got a huge influence in the way we look at, as a community, in the way we look at some of these conditions. So I just did wonder, what sort of work do you do with religious communities or leaders even to ensure that they stay well informed?
Yeah, that is a fantastic question, which I'm going to answer just because Modesta is relatively new to us. So in the past, so several years ago, we had a very large push towards outreach with religious leaders in particularly in Northampton, but also in other churches where the congregations would have been at higher risk for HIV. And I have to say that in recent years that has dropped off, but mainly because we aren't as clear as to who is the best person to approach. And part of us getting involved in this network and Anne very kindly letting us come and speak is because we really are keen to do that. And if there's anybody on the call tonight who is happy to speak to us afterwards, a couple of our outreach people are on the call as well. I'd be absolutely love to hear from you, because we've been hitting our heads against brick walls quite a lot of the time, and it's a very difficult thing. And I completely agree, unless we get those people on board, we're not really going to make a dent in it. You're probably aware of this, but there's quite a lot of good evidence from other places, particularly big cities, so Manchester, Birmingham, London, where the involvement of faith leaders has resulted in some really excellent outreach work, testing, and also kind of raising awareness, really, so that people can either test themselves or they can encourage other people to test, and that people can destigmatize HIV. But it is an uphill battle, I think. And I'm conscious that I'm probably not the best person to talk about those things, and that I would really welcome anybody who has some links that we could take forward. Oh, and Will's just put in the chat that he's very keen to help. I'm not sure if that didn't really answer the question, Rumbi, but yes, we do want to do that, and we've not been very successful so far.
No, that's absolutely fine, Sophie. I think I was also tapping into the research that you've already stated around the influence of faith leaders. But yeah, I'm happy to help. I'm in contact with some faith leaders. That would
be amazing. Yeah, I'd really welcome that. And you've made my day. So it's been on my agenda for a long time. Okay, let me just whiz through any more questions. So where are we? Scrolling down. Oh yeah, so how long can a person live with HIV without knowing that they have it? Is there a certain period of time before someone starts to experience symptoms? I could answer this, or Modesta, are you up for that?
You go ahead.
Me go ahead. Okay, so it's a complicated answer, but generally we would say that people could be living with HIV for anywhere between 2 and 10 years without knowing that they have it. But I think it's probably worth pointing out that when people are eventually diagnosed, if we do a look back, which we do for everybody, we often find that that person probably hasn't been very well for quite a long time, but that they had put the symptoms down to something else. So one of our roles is, as a kind of medical team, is to look back at some of the you know, when we're in contact with the GP, if the patient will let us write to them, is to have a look through the GP record and see, you know, what did that person present with to the GP in all that time. And, you know, quite often we might find that they had persistent shingles, or they presented with thrush in the mouth, or they had lots of chest infections. So looking back, that person probably wasn't quite well, but they weren't unwell with something that they associated with being HIV positive. So yeah, very, very variable. And also everybody's immune system is different. So some people will manage the virus very well. Their own immune system will fight it for many years, and they'll control it without getting sick. And for other people, their immune system isn't strong enough to do that. And there's still a lot of research going on as to why that is. We don't really understand why. Okay, so Florence has said about leaders. We'll say that. Here we are. How does male circumcision help in preventing HIV infection? If it does, how come it's not common practice in the Western countries? I can't. Oh yes, down in Africa. Oh, good. That's a really good question. Shall I answer that, Modester?
Yeah.
Or do you want to talk about circumcision from African point of view?
Yes. Circumcision helps in the prevention of HIV, in the sense that the foreskin itself is good. The cells in the foreskin are spaced out or whatever, so there is a high risk of catching HIV. Like, for example, if those fluids stays there under the foreskin for a long time as well, it can cause the risk of exposure becomes greater. But when you don't have foreskin and you don't have any like abrasions or bruises, so the risks, the chances of you catching it are less as well. And maybe you can also go deeper into it, Sophie.
No, I think you've summarized it really well. I mean, I think the important point about prevention is that all of the studies have been done on a kind of community basis. So we know with circumcision that on a personal basis, being circumcised protects against not just HIV, but other sexually transmitted infections, and in fact, some other skin conditions. But it's only when this has been tried at a population level, particularly in South Africa and some of the other Southern African countries, that they have noticed that it seems to reduce the incidence of infection in those people. So when we think about prevention, we're thinking about all of the tools that we've got at our disposal to prevent HIV, and it depends partly on the setting and how acceptable it is to do certain things. So we wouldn't routinely in the UK, for example, suggest that people get circumcised for prevention of STIs. And yet in some other countries in the world, because the access to other prevention methods might not have been so easy, and perhaps because circumcision was more commonplace anyway for cultural reasons or religious reasons, then they've been able to look at those studies and show that it's effective. So yes, I think that's a really good question, and I don't really know the answer as to why it's not taken off here, but I suspect there is a cultural side to that. Oh, Moochie, do you want us to unmute?
Yes, hi guys. I just thought I should come in on this one. So I come from Zimbabwe, one of the hotspots for HIV infections. But the reason I asked the question is because it must be 5 years ago, the statistics were that 60% of circumcised men, they'll come back 6 months later or a year later, they've been infected.
Okay.
So I'm against that notion of circumcision will save a lot of men from infections. It is deceptive.
Yeah, which is kind of, so I don't disagree with you, and obviously the stats are what they are, but it's part of a package of prevention, isn't it, in a particular setting. So another good example would be there's an intravaginal anti-HIV, antiviral gel, which is been trialed in Southern Africa for women. And the benefit of that was shown to be around 30%. So you would argue, wouldn't you, which is similar to circumcision, you know, on those statistics you've just shared kindly, you would say there's a 40% benefit. So that doesn't sound great, does it? 40%.
Not really.
No, but is that 40% better than nothing? That's the thing. So I think it's about putting it in context. Yes, I agree with you. 40% is not brilliant at all. But when you compare it to other prevention methods, the best prevention method we've got now is PrEP. And the studies for PrEP show that if you take it, well, two prevention things are amazing. One is treatment as prevention, which Modester very kindly, you know, clearly laid out that if a person living with HIV is taking their treatment, and if they're undetectable, they cannot pass the virus on. That's the first thing, and that's had the biggest effect. And the second thing is PrEP, so pre-exposure prophylaxis. When people take it, because it's a tablet at the moment, when people actually take it, it works brilliantly and is over 95% effective. Okay, so those are our two biggest things, and condom use. But I'm sure everybody on the call knows that negotiating condom use is not always very easy. So I think we've moved on in HIV kind of management to using the mantra that obviously, you know, oh, you should use a condom, you should use a condom. Well, we do advise people that condoms protect against HIV and other STIs, but we're very aware that negotiating condom use is not always possible for people, that they can't get hold of condoms, or that they have breaks and other issues. So yeah, I think your point is really valid, and thank you for sharing it. Because
and also if I can add, they are busy circumcising boys who are, I think, 7 or something like that. They just go to school, they ask to be circumcised, you sign the form, there you go. There's not enough information to those boys, because they are not always going to be 6 or 7, 9 or 10. There should be follow-ups until they are adults when they start engaging, because by then they will have forgotten why they don't have their foreskin.
Well, interestingly, I mean, this is an anecdote really, but you know, sometimes I see people in clinic, and I work in sexual health as well, so I examine a lot of people's genitals. And when I say to people, do you have a foreskin? And some people will say, oh yes, I've got a foreskin. And then I examine them, I'm like, I really think you haven't. Like there's I think some people just aren't aware of the differences in anatomy. And yeah, I mean, I agree. I don't think that circumcision I can't imagine it would ever be rolled out in that way in some countries where you've described them as Western countries. I think it wouldn't get through ethics.
Okay, I just want to add on Mochi to reply to Mochi. The thing is, while I was in Africa, the message that we were preaching was not circumcision. Only circumcision will help you not catch HIV. I remember we were saying, because there were some cultures who are of polygamous, they have got a lot of wives. So they sort of had a small study, and they have seen that to those cultures who practice circumcision and they've got maybe 3 wives or so, you find maybe one of the wives or the husband, whoever among those people, one of them is HIV positive, but you would see that the man, because is circumcised, they didn't catch the virus. So it's not really 100% effective. And like Sophie said, that it will be like 40%. And it's not a message that we would say, would tell people that get circumcised so that you don't get HIV. No, that would be deceiving people. But it was like sort of a package where just to help. So using condoms together with circumcision, of which condoms, like she said as well, people don't like to use condoms on regular basis. And sometimes they think about condoms after they did. So it's not safe to tell people to get circumcised and not get HIV, but it sort of reduces the chances as well. So it can be used as a package to help reduce HIV, but not on its own.
Yeah, very well put, Modester. Yeah, that Modester just explained it a lot better than me. So yeah, it's part of a package, isn't it? It's part of a package of measures that together can reduce risk. Sorry, my dog has just come to say hello. So there's a couple more questions. I'm just like to say thank you for everybody being so engaging. This is brilliant. So the next question is there data for the proportion of people with HIV who are LGBT plus? Yes, it depends on which data sets you look at. So the national data set would say that probably, so when you talk about LGBT plus, the data doesn't distinguish between different aspects within that. It would just say homosexual acquisition, men or women, but nothing else. And there is a little bit of data about trans people, but the data is pretty much 50-50. So 50% of the people living with HIV in the UK are men who have sex with other men, and 50% would be heterosexuals, or would identify as heterosexuals. And then Tish says, access to PrEP, is that now widely available? Yes, it is. Yes, it is. If you know anyone who would be interested in PrEP, or anyone on the call who's interested in PrEP, please just contact the clinic. I still need to put it into the chat. As I said, as Modester said in the talk, there's a web page you can go on. It's called It Starts With Me. If you think that PrEP, so prevention, might be suitable for you, you just go onto that. It asks you a few questions, a little bit about, how do you identify, you male, female or other, what sort of sex that you have, or what sort of partners you have sex with, and where those people are from in the world, and then it will tell you whether you would be considered eligible or not. So I would really encourage people to use that and to tell their friends and colleagues about it. We have put it out on our social media a while ago, but I might do it again. I'm conscious of time now. Yeah, Lauren says, do you find more LGBT plus community access PrEP than those in the African community? Absolutely. There's been a massive push nationally to raise awareness for PrEP amongst African communities, and lots of people, I think, are not perceiving themselves at risk or don't know about PrEP. So we're really trying to have a big push so that everybody who is eligible can access it. So just to give you a little bit of an idea, we've got over 200 people on PrEP currently at my clinic, and we have only two people who are heterosexual. And that's not right. There's many more people who are eligible. It's just that people haven't come forward. So yes, please spread the word. Also, I suppose what part of your comment, Lauren, in the chat was about people being part of a community that lobbied for it. So the gay community did lobby very hard to get PrEP and was very aware of it. And I think there's an awareness thing which has not quite filtered through yet. Francesca says, are there two types of HIV? Yes, there are. So type 1 and type 2. Type 1 is by far the most common. Type 2 is really only prevalent in Western Africa and bizarrely, well, not bizarrely because of migration, but Portugal. So we always think about that in people who've come here from there. And Will's put, PrEP and PEP has not been easily accessible in Northampton. There's a lot of distrust around the clinic. I think that's a fair point. So PEP, so post-exposure prophylaxis, the tablets you take if you think you've been at risk you need to get them within 72 hours. That's always been available. So that's a shame if people didn't know about that, because it's always available either in A&E or through a sexual health clinic. PrEP, I agree, has been very difficult. Unfortunately, in Northampton, we weren't able to roll it out. And we didn't have many places on the trial for it. So lots of people who were from Northampton came up to see me in Kettering, but that is now available. So again, please spread the word. Clinic not very friendly for those who are LGBT plus at the moment. I think that is a very fair point. Tish, we're trying really hard. So if you've got feedback on how you would like that to be better, please let us know. would really be welcome for that. And yeah, I'll have to stop talking so I can put our contact details in the box. Is that all right? So I think, Rumbi, did you have another question?
Yes, I do. Sorry.
Yes,
Sophie.
go for it. No, it's good. I'm going to type. So Modesta will have to answer this because I'm going to type.
Okay.
Yeah. No, that's fine. I just wanted to touch on, in terms of some of the young people that come through your clinic that probably find out because the transmission was through a parent. What sort of support is in place? Because it can be quite shocking news, I guess, for some of them. What sort of like support is there in place when they've just been informed that they've got a positive status? What support is in place to follow through with those young people?
Yeah, I should probably answer that actually. Do you mean people who are over 18 or under 18?
Over 18. I tend to work with young people between 16 to 25.
Yeah.
And I've heard some devastating stories, I guess, where they've been really impacted mentally.
Yeah.
And yeah, so I just do wonder what's in place to support young people like that.
Yeah, so really good question. So I trained for my specialist training in London, and I worked with the transition clinic from Great Ormond Street for nearly 2 to 3 years. So I've got a special interest in adolescents living with HIV who have acquired it either from vertically, so from their mother, or sexually acquired in their teenage years. And so in terms of what do we do for them? So I'm very aware that these people are quite isolated. So if you're diagnosed in pediatrics, so in children's clinic, there's a very big support network. So you'll have a specialist nurse, you'll see the doctor like fairly frequently. They plug you in with something called CHIVA, the Children's HIV Association. So there's quite a lot of cushioned support and psychology around that service. When those young people who might have maybe been diagnosed, have been infected for most of their lives, but diagnosed at say 14 or 15, when those people transition into adult care, the system is very different. So what I've tried to do in Northampton and Kettering is make it the transition as easy as possible. So we have had until recently a dedicated mobile phone so that people can text in and kind of don't have to hold on the phone to get through and ask for us. We've just set up a service called Chat Health, which is a texting service which has been used by our colleagues in the young people service. So what will happen then is that the young person just texts. It's a confidential support line. They just text through and it's answered. So they might have a question around, oh, I forgot a tablet, or I've just had sex with my boyfriend and the condom broke, or you know, I'm worried about telling my friends, or whatever. So there's a direct way into the clinic without them having to phone our telephone number. There's also I tend to plug them in with some support particularly through Body and Soul and Positively UK. There's also a support group in Leicester. And the other thing I do is we also ask our psychologists to see them, so that they usually, even if they're okay, I get them to see our psychologist so that there's a sort of initial assessment, that they know who she is, that they can access her anytime they need later on in their journey with HIV. So yes, it's complicated, and I'm sorry if the people that you have had a link with haven't had a great experience, but there is a plan in place. It might not always work as I like it to, but yeah, I feel very strongly that these people are faced with quite a lot of challenges as a young person, and having HIV on top of that is very difficult. I'm not making it sound like adults with HIV don't have a difficult time. They do, but I think there's a particular problem a particular challenge for young people. Okay, I hope that's answered the question. Where are we? So yes, so Will's put, can we stay on the call? I might get Will to unmute. Will, do you want anyone to stay on who wants to discuss LGBT feedback? Is he going to answer? He's disappeared. Right. I'm just putting our phone number in. So just to say that Modester and I both, oh, here's Will. What were we going to say, Will?
Sorry, what we were going to say is that there's actually a few of us from the same organisation on the call.
Yeah.
So we have some feedback for LGBT
Great
stuff.
Yeah, that's fantastic. So I'll hang on at the end then with you. That sounds good. And anyone who wants to stay is welcome. But that sounds great. So for everybody else, just to say, Modester and I both work cross-county. So we're both in Northampton and in Kettering. And I'm going to put the email address for the Kettering inbox in the chat and our telephone number. If you want to get in touch with us, I've got to remember it now. That's our main clinic line. I don't know the Northampton one off by heart, but if you want to get in touch with us about anything, they're the places. The other thing I just wanted to mention before we go is that anybody accessing care for HIV can go anywhere in the country. Now, obviously, if you live in Northamptonshire, we'd love to have you at our clinic, but we do appreciate that some people rather not go to a clinic on their doorstep, and that's absolutely fine. So some of our patients travel to us from quite far away. We have people who maybe travel an hour or two to come and see us because they started their journey with us and they want to stay with us. So if you do encounter anybody, or if there's anyone on the call who's unhappy with their care, wherever that is, you are allowed to go wherever you want in the country for your HIV care, and that is fine. Nobody will question it. They will just welcome you in. Okay, so it does make it a little bit difficult with sharing information with GPs and maybe for medication collection, but it is possible to go to a different clinic or for people out of the area to come to us if they wanted to. Great. Thank you, everybody. Oh, thank you, everybody. And do you want to say anything to close?
Yeah, sure. This has been really, really great. It's been a fantastic presentation, and it's good to have kind of more than one person from the medical team to be on the call, so you get different answers. As I mentioned before, this is part of a health inequalities project between the United African Association and NHS and NHFT. So we're just bringing you different Zoom sessions about health conditions that affect the Black and Asian and African Caribbean communities. And we hope to hold a lot more sessions then, but this has been absolutely fantastic. I am in contact with quite a few of the people who've made contributions there. So if they've got any calls and if they miss anything, say for example, Rumbi and Muchi, then I can contact them direct. And if you want to get in touch with anybody, just let me know there. But it's been absolutely fantastic, and we're happy for you to carry on the
thank you so much for having us. And yes, please use Anne as a go-between. Is that all right?
That's absolutely fine. Yes, thank you.
Take care, everybody.
Amazing presentation.
Thank you, everybody.
Well done, everyone.
It was an amazing
team
having you here. Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Will, I'm staying. I'm definitely staying.
We'll get you back.
Yeah, I know.
Thank you, Sophie. Thank you so much.
You were brilliant. Love you. I wish you'd come to work for us years ago.
Stop it. Oh my goodness.
I know.
You did everything for me. Thank you so much.
Right, go and enjoy your evening.
Bye.
Bye.